Good morning to everybody. Bom dia. Bom dia. That's only what I know about Portuguese. Thank you very much for the invitation. I am very proud to be here to speak with in front of this qualified audience. So I think that Dr. Youssef during the presentation defined very well what is the real meaning of slow medicine. That's to go back to the real medicine and to treat really human being and not to use technology to help to help the diagnostic process, but technology shouldn't become the only way to interfere with the patient. So can I have the first slide? There. I'm sorry, I couldn't see. And okay. First of all, I want to introduce myself because this is one of the campaigns that slow medicine launched in Italy in the last few years. Because we think that the first step to become a slow doctor, a doctor who take care of a patient, is to start a human relationship before then a scientific or clinical relationship. So the first step is always to introduce yourself. I don't know what happens here in Brazil, but in Italy, very often physicians, nurses, anyone comes inside the room where patients are and start to ask questions, to do some procedures, and the patient doesn't know who is in front of them. So I think that the first step to start a real slow medicine is to start with a human relationship with the patient. Well, I've been invited to describe you what happened in Italy in the last few years. So we launched the association, the Slow Medicine Association, but we also started to do projects all over Italy in order to organize hospitals, in order to make them more oriented in the patient care. Those are the hospitals scattered in the Italian territory that joined the project of the net of the slow hospitals. Well, and we organized still now two national meetings of the slow hospital. The first one in 2015 in the city of Cuneo, where I worked, as Dario Birolini told you, and the second one just a few months ago in Arezzo. But before explaining what we did, I have to do a step back in order to explain from what consideration we started. We started from the choosing wisely experience. That the next speaker will speak you more precisely. But unfortunately, I cannot read the slides from there. And could you hear me? Yes. Okay. Choosing Wisely is an initiative of the ABIM Foundation to help physicians and patients engage in conversations about the overuse of unnecessary tests and procedures and support physicians' efforts to help patients make care choices based on clinical evidence and on their preference. Educate patients about when they might need a particular test or treatment and when they don't. And finally, encourage patients to talk with their doctor about unnecessary tests. That's the reason why 5 questions have been defined that patient should ask the physicians. Do I really need this test or procedure? What are the risks? Are there simpler, safer options? What happens if I don't do anything? How much does it cost? So we have to teach patients to ask the right question to patients. And Jose Carlos yesterday told me that also here, a couple of days ago in this journal, Estado, the 5 questions have been translated and used here in Brazil. So the principle of choosing wisely are becoming more common also here in Brazil. Well, the campaign is based on the idea that specialty societies develop a top 5 list of health procedures of which patients and physicians and patients should discuss because they could be unnecessary and potentially harmful. As Dr. Youssef described before about the history of bacteria, the knowledge of bacteria and antibiotics, we can conclude his history that now if we use antibiotics in an unnecessary way, we can create bacteria resistance. And so antibiotics that are so useful to treat infective disease, if we use them in an inappropriate way, we waste a lot of therapeutic resources. And for example, Italy and Greece in Europe are the 2 states in which there is the highest consume of antibiotics, but also are the 2 states in which the highest rate of resistant bacteria. So the overuse of a very effective treatment can be harm our patients and the population. So this is an example. I show you just as an example of what is a list of procedures at risk of inappropriateness. Well, in 2011, while in the United States Choosing Wisely was launched, in Italy we founded the slow medicine movement. Slow medicine movement starts from the slow food movement that I think most of you know. That's a movement for an appropriate use of food in contrast with the fast food chains of food. Well, the logo of fast food is a snail. We decided to use as a logo 2 snails because it's the representation of a physician and the patient that are speaking together about slow medicine. Well, the manifesto of slow medicine, here we have the Brazilian version, is that we are fighting for a medicina sobria, respeitosa e justa. And so I agree with Yusuf that we shouldn't use the term slow, because this is exactly the medicine we should practice. But anyway, it's interesting that we have to add the adjective slow to define the medicine that we would like to practice. So also in Italy, in June 2017, 14 scientific societies identified the practice at risk of inappropriateness, and 2010 recommendation has been published so far. Also in Italy, we are working with consumer association, Altro Consumo, and they prepared the brochure to explain patients what does it mean, an overuse of such procedures. Well, that's the reason why at the beginning of this year I published a second book that's called Too Much Medicine. An excessive use can harm your health. And since the first one, O Doente Imaginado, has been published here and had a great success, I hope that it's possible to translate also this one for all the physicians and citizens of Brazil. Well, starting from the Choosing Wisely experience, in our hospital in Cuneo, that's a small city in the western corner of Italy, close to the French border, we started a new experience. This hospital has about 700 beds, 400 physicians, 2,000 employees, and the clinical activity in all, any kind of department, heart surgery, neurosurgery, neonatal intensive care, interventional radiology, and so on. Well, we started from this challenge. Why don't we apply the Choosing Wisely rules designed for scientific societies to a hospital? Aren't physicians able to identify what they are doing in an appropriate way? Well, so we decided to identify 3 procedures at risk of inappropriateness in each department through a shared procedure of brainstorming, within each department, physicians were invited to collectively choose 3 procedures inappropriately prescribed by themselves. So a sort of self-evaluation of what they were doing wrong. When we started this process, everyone said, but I'm doing everything in an appropriate way. All what I do is right. But then thinking deeply and discussing in a sort of brainstorming in each department the 3 major procedures that are prescribed, they are often prescribed in an appropriate way, have been identified. So we identified a steering committee, including a young physician of each department. In each department, several meetings were organized to identify a list of inappropriate procedures that are usually prescribed during hospital stay of the patients, and the 3 most relevant procedures were chosen by consensus. So we identified 96 procedures and so on. So we published a brochure that is called Fare di più non significa fare meglio. That means doing more does not mean doing better. And here is the list of all the departments that joined the project. As far as we know, this was the first project developed at the hospital level, since previously only scientific societies were involved in national levels. In this case, physicians have to choose which procedure they should avoid. Which are the main strengths of the project? A bottom-up organization set up by a group of physicians and not by the director of the hospital. So the physicians thought that it was something useful for them, not something that was useful for the hospital. So it was useful to be better physicians, to practice a better medicine. Young physicians of each department, were involved in the steering committee. Most of clinical departments participated in the project. Wide brainstorming involving the whole medical staff. Here is, for example, the experience, what has been prepared by the gastroenterology department, and they said one of their recommendations were do not request routine blood analysis when patients are admitted in the ward coming from the emergency department, because in Italy we are accustomed to, when a patient is admitted in the ward, to ask a set of exams, regardless what the patient has done in the emergency room after 1 hour before, 2 hours before. So just a simple recommendation. In a year, reduce the number of blood tests from 52,000 to 46,000, even if the number of patients admitted in the gastroenterology department increased. So the number of blood tests per patient were reduced by 81 to 68, so by 13 blood tests during 1 year. Then, after 1 year, each department reevaluated their procedures to verify whether they were clinically irrelevant, have already been reached, are unreachable, should be partially modified to make them more effective. So, and then they identified methods to assess and measure process and outcomes. And also the nurses started to define which procedures are done in an appropriate way. And this is their list. Do not perform mechanical bowel preparation for elective surgery. Do not use disposable overshoes in emergency departments unless is required in very few departments. Reduce time of urinary catheter use. Do not waste disposable sterile gloves, but adopt an appropriate hand hygiene. And also, you heard before the story of Summerwells. Do not prescribe prolonged fasting after cesarean delivery. Do not prescribe oral nutrition support without a definite plan. So I think that the major issue of this experience is that the whole hospital was involved in deciding to avoid inappropriate procedures. Well, in June, we had the second national meeting of the slow hospitals, and here are the first results. From the hospital of Cuneo, we had a reduction between the first and the second semester of 2016 of 4.7% of intravenous antibiotics consumption, a reduction of 12% of oral PPI and 34% of intravenous PPI consumption. 28% reduction of the number of chest radiograms before discharge. Because sometimes physicians prescribe chest x-rays without a real reason, just to be sure that everything is going well. And the number of pre-operative laboratory tests for low-risk surgery. In the Arezzo Hospital, 22% overall reduction of laboratory tests in 5 medical departments. In the Alessandria Hospital, 4% reduction of laboratory tests per day of hospitalization in the whole hospital. Well, we prepared also a booklet explaining what is the project, how can be developed, what are the importance, the aims, the results that can be done. And if you are interested, it can be translated into Portuguese, of course. So just to finish my presentation, I give you an overview of what was the experience with the net of the Slow Hospital. The aim of the network of Slow Hospital is to reduce the risk of inappropriate practices and to provide everyone with proven underused procedures. Because if we waste resources, we do not have resources for people who cannot be adequately treated. To improve communication and the relationship between health professionals and patients. To involve patients and citizens toward their health choices. to implement initiatives to raise the attention of the hospital to the needs of patients: hospital comfort, safety, noise, privacy, open intensive cares, areas for patients association, etc. Phases of the project: constitution of the network, dissemination of the project to the higher number of hospitals all over Italy, training of physicians and nurses to be slow physicians and slow nurses, local identification of inappropriate practices at risk of inappropriateness, implementing practices identified within healthcare organizations, developing information for patients and citizens, quantitative and qualitative evaluation of the impact of project, comparison of outcomes within network health organization. Main strengths of the project: again, bottom-up campaign, enhances the professionalism of physicians and nurses for the health of their patients. So they must understand that reducing inappropriateness, being more close to their patients, make them better physicians and better nurses. Focus on do not harm campaign, not a way of rationing, but a way to do a better medicine. Partnership between healthcare professionals and patients and citizens. Change of culture and of paradigm. The slow medicine philosophy that José Carlos explained you in the next presentation. Main challenges: to activate and join national project for implementation of recommendations and evaluation of results. To support physicians concerned about complaints and litigation, defensive medicine. So we have to give rules in order to protect physicians in case of legal litigations. To invest in training on communication with patients and families and on decision sharing, both in medical schools and in subsequent education of physicians. To fight the common media's message that the new is always better, as well as doing more means doing better. So we have to work a lot with the media because most of the media stresses the idea that the new is always better and that you should do as much as possible for the patients in order to save them. But sometimes, and we know for our experience as physicians and nurses, that sometimes doing a step backward it's better. You can wait a little bit, as Dario Birolini explained. Sometimes it's better doing nothing. Just relax and keep your health. What next? So each hospital should invest in the evidence-based medicine and especially in overuse of tests and treatments about the benefits and risks of identified practices. Develop skills in the interpretation of the results of clinical trials. Strengthen ethical and deontological protocols regarding the choice of care. Analyze prejudices, assumptions, attitudes toward care of and patients. Activation of narrative medicine projects. Developed communication and relationships skills with patients and peers. Improve the patient-physician relationship. And so we are in the middle of this project. Of course, I cannot tell you which will be the results in the next few years, but I think that there is several hospitals joined the project, and I think that in the next few years we'll be able to give you more results of how changed the medicine in the hospital that accepted to join the project. Those are the books that we have published since now. The first one is the major book, the core book of slow medicine, why medicine sobria, rispettosa, giusta is possible. The second one, the words of a medicine, of a changing medicine. Then most of you know Odorente Immaginato, and the last one, Troppa Medicina. Thank you very much for your attention.